The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device. Welcome to Spot the Bleed, an American Heart Association ICH Guideline Refresher Series, the podcast dedicated to providing comprehensive insights in hemorrhagic stroke care. I'm your host, Sue Abel, Program Consultant at the American Heart Association. We're excited to bring you content that addresses guideline-directed care across the continuum, from patient diagnosis, treatment, and all the way through secondary prevention. In each episode, you will hear from our clinical experts as they break down the ICH guidelines into tangible offerings. Thank you for joining us today as we aim to equip you with refreshed knowledge to enhance ICH care and drive positive outcomes. Let's get started.
All right, well, welcome to the show today. So my name is Tom Grawey. I'm an emergency medicine and EMS physician over at the Medical College of Wisconsin in Milwaukee. And I'm here with two great guests, two emergency medicine physicians who I love working with at MCW, Mary Jordan and Erica Forbes. So go ahead and say hello.
Hi, it's nice for everyone listening.
Hello, thanks for having us.
Great. So we are going to spend some time today talking about intracranial hemorrhage care in the emergency department. So we'll go through a little bit of a case of somebody who presents with ICH. We'll then talk about some management tips and kind of close out by talking about how we reproduce good results and how we build good ICH systems of care. Because the key is not to manage one patient successfully with an intracranial hemorrhage, but to really make sure that every patient that comes in with this diagnosis, no matter the time of day that they have it or the presentation, we are able to identify it and treat it appropriately for all patients. So Mary, why don't you start us off by just giving us a case?
Yeah, absolutely. So the case that we have for today to kind of discuss starts in the field. So EMS activates a code stroke. And you get a page in the emergency department of a 76-year-old female, left-sided weakness and numbness with a last known well of about 1 hour prior on Eliquis. Vitals, her heart rate is 88, her blood pressure is 180/90, her temperature is 98.6, she's breathing at a respiratory rate of 14, and she's statting 98%. So the patient arrives in your department, and you get a pretty similar handoff from EMS. And what you note is that she has a history of atrial fibrillation on Eliquis, high blood pressure, hyperlipidemia, and coronary artery disease. And family called initially because they were worried that she was more confused than usual. She was at home with her husband watching football when she started to feel unwell. She told him she had a pretty severe headache and that she was having trouble and feeling weaker than usual. So they called EMS. She describes to you that she has a headache and that her left arm and left leg are really weak. Family noted that she wasn't really looking towards the left side of her body. She woke up this morning, felt fine, but did get nauseous at one point at home and had an episode of emesis with EMS. No recent falls or traumatic injuries that she can tell you or family can tell you. She's otherwise feeling okay, no fevers, no infectious symptoms. She said she takes all of her medications as prescribed. Most recently took her Eliquis this morning, about 8 hours prior to coming to the emergency room. Otherwise, she's never had any symptoms like this before. Not having chest pain or shortness of breath, and your review of systems is otherwise negative. Her vital signs in the emergency department are pretty similar to what you noted with EMS. She's hypertensive, but otherwise vitals are normal. On exam, you notice severe hemi-neglect of the left side of her body, and she has some right gaze deviation. She has 0 out of 5 strength in her upper and lower extremity on the left, and 5 out of 5 strength in her upper and lower extremity on the right. She also has no sensation on the left side of her body. She's otherwise alert, responding to questions as you would expect, and kind of following commands. Her language is unaffected, and the rest of her exam is unremarkable.
Great. So a great case that should already have us thinking about a pretty wide differential, ischemic stroke, hemorrhagic stroke, some other things that can cause altered mental status and weakness in patients. So Erica, when you hear this patient, when you hear this patient's coming in by EMS, before we get to the ER care, like what are you going to be preparing in your emergency department to get ready to receive this patient?
Yeah, so I usually, in preparation for these kinds of patients, we will, as this was called out as a stroke code, we'll make sure like we have our neurologist coming down to quickly evaluate the patient. I know I'm quickly going to need to get a neuro exam when the patient comes in after we get our set of vitals. One of the things we want to make sure we're aware of is the patient's glucose. We want to make sure to check the patient's glucose when they get there. So I'm making sure my nursing staff is aware that that's going to be a priority for us once the patient arrives, just because sometimes having a low glucose can cause to be have some altered mental status as well. I also want to make sure I have my pharmacy ready, the pharmacy team ready, just because as we later found out when this patient arrived, they're on Eliquis, and if there's any sort of intracranial hemorrhage, things we want to think about are reversing any types of anticoagulation. So I want to make sure my pharmacy team is understanding and aware that that might be an option for us.
Great. So you talked about getting a lot of people ready to receive this patient that, is obviously critically ill with their signs and symptoms, with this hematogalactic weakness that EMS is talking about. And even if you don't have pharmacy, at your shop, it's good to think about, all right, I might need to reverse, and what agents do I use? It's certainly a lot more complicated to reverse than back in the day when everybody was on, Coumadin, and there was one answer for that question, right? So this patient comes in, with the signs and symptoms that Mary described. What here is kind of making you think or have a high suspicion for intracranial hemorrhage as a etiology?
So this patient had sudden onset of symptoms. It wasn't something that necessarily gradually, crept up. And they also are having a headache with nausea and vomiting. Those in itself kind of scream, is there an intracranial hemorrhage occurring currently in concordance with the neurologic symptoms that I'm seeing on exam? Especially in the setting of this patient is on anticoagulation, that makes me think this is more likely to be a hemorrhagic stroke versus an ischemic stroke.
Okay, great. So you highlighted a lot of good things, that while your differential is broad, that point that we are really concerned about an ICH, which is something that we need to intervene and act on, very quickly. So, a big part of the first thing that you're going to do when this patient gets to the emergency department is obviously get them to the CAT scan as soon as you can. And let's say you do that and you find that this patient's having a right-sided intracerebral hematoma with some involvement of the basal ganglia and lobar structures. So you get this read from the CT, either the radiologist is calling you and letting you know about it, or let's say that you're, in the CT scanner and this image is coming up on the screen and you see it as soon as it's popping in. What are your initial principles of management that you need to get to? And there is a lot going on here. So let's try to break it down into some different categories and some things that you're thinking about. So why don't you tell us a little bit about blood pressure monitoring and how you would address that in this patient?
Yeah, absolutely. So blood pressure monitoring is pretty important in these kinds of patients. You want to think smooth and sustained blood pressure. You don't want big spikes high and low in their blood pressure. Research has shown that maintaining it around 130 to 150 is safe and beneficial, but you really don't want to drop it below 130 as this can be harmful. And you want to make sure that, when we're lowering our blood pressure, specifically our systolic, we want to avoid any large variability within the systolic blood pressure because that can just cause increases or expansion of our intracranial hemorrhage.
Okay. So yeah, and when managing blood pressure, there are a couple different agents that you could reach for if you're thinking IV and things that'll work quickly. So hydralazine, labetalol, nicardipine drip is another common one. What's kind of your go-to plan for somebody to help make sure that you're getting this like smooth and sustained management of blood pressure?
I usually start with labetalol or hydralazine first, but I typically will start towards labetalol first, and I'll start off with lower doses and see how the patient responds, and see then if I need to add any additional agents or increase the dosing, I can do that. If I'm then unable to get a good control of the blood pressure based on just giving them some doses of blood pressure medications, then that's usually when I'll start putting the patient on like a nicardipine drip to keep a better, slower, sustained blood pressure goal for them.
Okay, great. Mary, do you have any other thoughts on blood pressure monitoring?
I tend to like to start the drip, especially with a more severe intracranial hemorrhage, kind of right away. I think that it leads to that kind of more smooth and sustained goal. And oftentimes these patients kind of tend towards being bradycardic. But certainly depending on the situation and the degree of bleeding, I like a push dose to start if they're kind of more stable and it's a bit of a smaller bleed.
Great. Yeah, and I think there certainly is like variability, and how different providers would get there. I think one thing to consider is depending upon where you work, you might have more quick access to different agents, which might determine what you reach for first. Certainly kind of going for a push dose medicine is usually quicker than getting a drip up, and personally, like my practice is probably a little bit between the both of you. If it's somebody that's like really close to where I want them to be, then I'll start with, one dose of, labetalol or hydralazine, kind of depending on some patient factors. But we'll reach for, an nicardipine if they're extremely hypertensive. And I know that I'm probably going to be going that route anyway, but it is usually, but usually I will give, at least one dose of something else en route. So, we'll get that set up. So, all right, so we got blood pressure monitoring covered. What about anticoagulation reversal? So this patient's on Eliquis. So tell us a little bit about how you'd approach that in this patient.
Yeah, so whenever patients come in on any type of anticoagulation, there's concern for hemorrhage, what we want to do is reverse the anticoagulation, just because patients that have intracranial hemorrhage that are on blood thinners have a higher risk of poor outcome and expansion of their hematoma due to the blood thinners themselves. So it's really crucial to reverse this. So this patient was on Eliquis, which commonly is reversed with PCC, or the brand name that we kind of use is Kcentra, as some might colloquially know. So that would typically, this or andexanet alpha could also help reverse the patient too, but PCC is generally more available in emergency departments and would be easier to reverse and just like grab for first for these types of patients. Other things that PCC can help reverse are warfarin as well. That will reverse the patient quicker than things like vitamin K, which are commonly thought to use with reversal of warfarin. PCC can do this over a shorter amount of time. So that's crucial when you have a patient coming in on warfarin with an ICH. Then there are less common anticoagulation that we see in patients. I can't tell you the last time I saw a patient with dabigatran coming in. That's not necessarily one that we commonly see, but there's a monoclonal antibody, idrocuzumab, that you can give to reverse this anticoagulation. And then for heparin or low molecular weight heparin, we can give protamine as well, and this can help reverse those patients.
Great, and I think it's important to know like the time of when they last took that last dose, because that might impact whether you're going to reverse or not, because they might be on Eliquis or pick your medication, but maybe you've got a really good history that tells you that they haven't taken it in a few weeks. But when in doubt, always, err on the side of reversal. So this patient isn't on any antiplatelet medications, but, what are your thoughts on reversing, aspirin, Plavix by giving platelets?
It's generally not recommended to do that. I know a lot of times our neurosurgeons want to especially know when a patient comes in on aspirin because they are worried about platelet dysfunction in these patients. But according to our guidelines, it's not necessarily recommended.
Okay. All right. So
the other thing,
go ahead. Sorry.
I was just going to say the other thing I think about too with anticoagulation reversal is you can order a factor 10A level if a patient's coming in and you don't have a clear history of when they last took their blood thinner. And at least in our lab, it results pretty quick, and it gives you a good indicator of whether they've been taking that anticoagulation and whether they're going to need that immediate reversal.
Okay. Great point. So if that's something that's also, available to you where at the hospital where you're working, it's something to consider. Great. So tell us a little bit about glucose monitoring and temperature management in these patients.
Yeah, so for glucose and temperature, really the name of the game is going to be keeping things normal. So there's no universal guidelines for glucose monitoring in patients with ICH, but we want to make sure that they're not hyperglycemic, as this has shown to have increased a higher risk of mortality. It should be wanting to maintain kind of normoglycemia in these patients. And it's generally the same with temperature management as well. So these patients will commonly have a fever, and having a sustained fever has shown to have poor outcomes in these patients, but hypothermia hasn't necessarily been shown to help these types of patients. So we really just want to make sure they're not sustained having fevers. So you can consider treating fevers that they are having. But I really think about just making these patients kind of as normal as we can.
Great. So I think that's a good theme that even kind of gets with blood pressure monitoring to an extent in anticoagulation. You're trying to make the glucose normal if possible, temperature management, focus on normal levels. Blood pressure to an extent, like we had talked about, we don't want to drop anybody too quick, and we're maybe a little bit above normal if possible. But then anticoagulation, trying to get that back to more of a normal state. So all good things, putting patients in a situation where we're not adding extra insult to raise ICP, or doing things that are going to cause the bleeding to necessarily get worse. So what are some things that people may have done in the past or, may think about with other brain-related emergencies that generally aren't recommended for ICH patients?
I know in the past they used to give steroids for these types of patients, which actually has not shown to improve outcomes. So steroids should generally be avoided in these patients. There's also not great evidence on empiric seizure prophylaxis. It doesn't improve outcomes, and when there's no evidence of seizures. So jumping just empirically to, give a patient Keppra or give them steroids has not actually been shown to improve outcomes in these patients.
Good. Yeah, so that's really, really helpful too. You want to, especially when we want to focus this period of time right after diagnosis on things that are going to make a difference. Really focus on the things that we addressed earlier with anticoagulation, reversal, managing blood pressure. Don't need to, get worked up about steroids, seizure, platelets. Like those things are not going to help patients, generally. So, all right. So, let's say that you've got your patient in front of you, that we presented. What's going to give you some concern that the ICP is rising and that this patient's getting sicker?
Yeah, so that is one of the biggest concerns for these patients as their hemorrhage is at risk of expanding. They are at risk of herniating. So the things we look for are kind of what we call Cushing's triad. So this is hypertension, The patient will also be bradycardic and have an abnormal respiratory rate. So whenever we're concerned that the patient is herniating, what we'll consider for these patients are hypertonics, such as 3% saline or mannitol. Whatever you have in your institution would work well for patients who are herniating. I know I generally will go towards 3% saline first, but there hasn't necessarily been shown any improvement of patients if you're on a continuous hyperosmolar therapy. So these are generally given in boluses if we can. Also, what we can do to avoid increased intracranial pressure is we can elevate the head of the bed to at least 30 degrees. That just helps with cerebral blood flow. Also treating any pain. And if the patient if their GCS is decreasing and they need temporary hyperventilation, and you're able to do that and kind of control their respirations, hyperventilating the patient can also help decrease intracranial pressure as well.
Great. Yeah, generally, what I think of with hyperventilation is this is not a person, if they're intubated, that we want to have them hyperventilated on the vent, because it's very easy to set the vent at a hyperventilation rate and then walk away, and forget about it. Next thing you know, you've been hyperventilating the patient for an hour. So this is something that you want to do acutely with a bag valve mask, so that you're being very, very aware, very deliberate in how much hyperventilation you're providing to try to temporize herniation. Great points on Cushing's triad. I think the thing that I also think about is if that GCS is rapidly decreasing, that's a sign that herniation's on the way. And Cushing's triad is a great thing to look out for, and sometimes that can be a late finding. So in addition to that, just thinking about this rapidly decreasing GCS is something that should really make me worry that herniation is impending or maybe even actively happening at this time. So we've got the sick patient, and obviously we need to call neurosurgery to try to help out with this bleeding that we have. What can you tell us a little bit about, from the emergency medicine standpoint, what we're looking for with this neurosurgery consult, what they might help us out with?
Yeah, so patients who have a large or severe intracranial hemorrhage may require surgical decompression. So that's why it's important to get neurosurgery on board early. A lot of times, patients who also have ICH can be closer monitored on the neurosurgery service or in the neuro ICU, and they will place a bolt or drain to help facilitate knowing what the intracranial pressure is, or decompressing the skull by getting some of that blood out.
Okay, great. And yeah, they're going to be the ones that are going to help determine who's that surgical candidate and what they need. So definitely getting them on board, whether that's locally or giving a call to a neurosurgeon at a tertiary care center, so you can quickly get this patient, transferred to the hospital where they can get that intervention is really important. So tell us a little bit about the ICH severity score and what we might use that for in the emergency department, and why it's important for us to think about calculating this on our patients.
Yeah, so the ICH severity score helps us provide risk stratification of the patient. Basically, if the patient has their age is over 80, the size of the bleed is over 30 milliliters, which we can calculate on the CT head. There's an intraventricular hemorrhage. There's an infratentorial origin of the hemorrhage, and there's a lower GCS. Then this will predict a worse outcome for the patient. Again, this is a severity score, so you can have a higher risk or a lower risk, but if you have 4 points based off of GCS, age, site of bleed, or size of bleed, 4 points predicts a 97% mortality rate. And this is our most validated tool to help stratify patients with ICH.
Okay, great. I think another thing, is that this could be trended a little bit as well. So you can, monitor changing GCS. You can monitor, change in size of bleed as things that might help later on with repeat imaging to figure out what direction this patient, may or may not be heading in, or what their mortality may or may not be. But all that being said, severity scales can be used to help measure the size of hemorrhage, but really shouldn't be used as the sole factor in deciding to discontinue treatment. So there are a lot of different factors that need to be considered, and this is definitely a decision that I like to have with my neurosurgery colleagues, instead of providing recommendations myself to family on kind of what appropriate interventions might be, even if I know that that things are going to be pretty bleak outlook here. So Mary presented you with this patient, and there was a lot of different things that we needed to do to emergently stabilize this patient in our emergency department. So why don't you just kind of summarize, Erica, what your goals are, what you're going to do as soon as you are in the CT scanner, you look at the CT scan, you find out that this patient has this kind of bleed.
Yeah, so the first thing we want to do is, maintain that blood pressure. We can start a nicardipine drip just to maintain that blood pressure under 180. Looks like when the patient went to the CT scanner and presented to the ED, it was around 180. We'd also give PCC for reversal for the Eliquis and make sure to elevate the head of bed. And then basically our definitive kind of treatment for this patient is going to be getting neurosurgery on board and getting their recommendations. So getting an urgent consult from neurosurgery, as they may need to admit the patient to a neuro ICU.
Okay, great. So I think if we were going to summarize, what things we're considering, it's about bringing blood pressure down to a more closer to normal, a little high, higher end of normal range, and then try to make a lot of other things normal. Even though we might give 3% saline, we're not trying to make this patient hypernatremic. We want to ventilate them appropriately, maybe some brief ventilation if they're herniating, but focus on normal temperature, normal blood sugar, get neurosurgery on board and admit the patient to the neuro ICU. And just a little plug for one of our other episodes, we talk about nicardipine drip here. Depending on whether you're sending this patient out and what capabilities you might have with your EMS agency that would be transferring this patient, that might actually impact what blood pressure medications you might want to start or use. So just a plug for the other episode that we have on EMS management, where we'll talk about preparing patients for interfacility transport. So Mary, you hooked up Erica with this challenging case that she, was able to successfully manage. But tell us a little bit about how we build these, ICH systems of care. So we make sure that all of our patients that come in with this diagnosis get the best care possible. What are some components of that?
I think, trying to manage these patients is very challenging. So having kind of the framework at each step is super important. Making sure that EMS crews are able to recognize stroke early and notify the hospital so that they can prepare. Similarly, within the hospital, there are FAST teams, which are stroke response teams that allow for early recognition of stroke signs and symptoms, as well as notification of the appropriate teams and kind of mobilization of those resources. This is really a multidisciplinary effort to help streamline treatment. That will be with your EMS crews, your nursing staff, your pharmacists, and your physicians. We all work together, in the emergency department as well as in the hospital to care for these patients. So kind of having some of the plans for stroke management streamlined among the different disciplines is very helpful. This is with things like anticoagulant reversal, making sure pharmacy is aware that you have a patient coming in with anticoagulant reversal and kind of having each level trained on that, as well as things like order sets that kind of streamline the ordering process and get things started right away. And certainly having kind of a streamlined plan for definitive care once you've kind of emergently stabilized them in the emergency room. going forward is also super important.
Great. Erica, anything else to add? Any other big things that jump out for you when you're thinking about systems of care?
Yeah, especially when Mary was discussing the order sets and regulation reversal. I know at least in the institution that we work at, we have a multidisciplinary guideline that we are able to follow that was created by and discussed upon the emergency physicians, neurosurgery team, pharmacy was on board. And then I think we even at least got like hematology on board as well to discuss, what in our system specific dosing and indications are given so we can have anticoagulation, everyone's on the same page. And this makes it easier. So when you go to, consult neurosurgery, they're not telling you to give one thing or a different dose or anything like that. This is the guideline for our hospital. That's kind of what we follow. The same kind of with the order sets, making sure everything's kind of in one place. It takes away, us having to think about what exactly will our consultants need. We have it all in one place and we can order it with a patient.
Yeah, and I really love the idea of order sets and checklists. And I'm kind of a nerd about checklists with my ER care and what I do with EMS agencies that I work with. But especially with something like this, I mean, there's so many different moving parts to management. And add that this patient could be, decompensating quickly in front of you. Maybe you've got another sick patient in the bed next door. You're by yourself in a low resource emergency department. I teach, this topic to paramedic students every year. And, that being said, and I teach this to residents, that being said, I still make mistakes if I'm not looking back on an order set or, confirming with my checklist, because you might be very well intentioned to order that, that anticoagulation reversal, but while you're getting ready to go put that in the computer, you get pulled somewhere else. And next thing you know, you're on the phone with neurosurgery and they're like, oh, did you reverse the Coumadin? And you're like, shoot, I didn't get a chance to do that, despite knowing full well that that's really important in the management for this patient. So really relying on those things is really, really important. And I think the other thing that jumps to mind, and in addition to the things that you guys said, is, I think this is a great way to decide what we need to stock in our emergency department. If we have a order set, if we have a pathway that's agreed upon multiple specialists, that this is how we're going to manage a certain subset of patients, be that for ICH, status epilepticus, whatnot, that tells you what drugs you need rapid access to in the resuscitation area of your emergency department, so you're able to manage those effectively. And then one more thing that I'll bring up is thinking about, with this streamline to definitive care, how you do things in multiple things working at once. You know that this patient's going to need to be transferred out, and 100% of the patients that you transfer out go to hospital A. Think about, if it might take a while to get EMS on the phone, how could you maybe mobilize them while you're waiting to hear back from hospital A? This patient's not going to be staying here, so maybe we can get EMS kind of coming our way instead of waiting until we are formally accepted and then, calling EMS to come get the patients. So, great. Mary, you want to tell us a little bit more about comprehensive stroke committees and how these can help make sure that we are reproducing good results?
Yeah, absolutely. I think, the comprehensive stroke committees are another tool to help, have every player in this setting kind of on the same page. These stroke committees kind of follow the Joint Commission guidelines and help hospital systems to achieve the core measures when it comes to stroke evaluation and treatment, and are part of kind of being a high reliability organization with patients who are severely ill. It's important to evaluate these cases and continue to perform quality improvement assessments to make sure that we're meeting the standards for stroke assessment and treatment, and to ultimately make sure we're treating patients and achieving our desired outcomes.
Great. So Erica, Mary, I really want to thank you guys for helping me cover this really important topic. Intracranial hemorrhage. Erica, why don't you just summarize some of the take-home points that we've talked about today?
Yeah, so kind of the biggest thing, especially in the field, is kind of that rapid identification of these patients and to transport these patients with suspected ICH to a hospital as quickly as possible. These symptoms include headache, nausea, vomiting, acute onset, focal neurological deficits. Sometimes these patients can just have some altered mental status, or seizures could also be present as well. So making sure these patients are getting to a hospital, and then ensuring that, once they get to the emergency department, we're controlling their blood pressure, making sure it's smooth and sustained. We are thinking about anticoagulant reversal, trying to monitor that intracranial pressure by doing things like elevating out of bed, make sure we're treating pain. And then if we need to give any additional medications to prevent the patient from herniating, we have those on standby or give them to the patient. And then really making sure, we're getting a neurosurgery consult quickly and to make sure that this patient's going to get their definitive care. Using scoring tools like the ICHSS, or the intracranial hemorrhage severity score, can help predict kind of the severity, and we'll be able to monitor these throughout the patient's stay, but they should not be used as the sole factor, like we had talked about, kind of discontinuing treatment. And then in terms of systems, really making sure you have like a multidisciplinary team that plans ahead for these patients, and to make sure that we have like a standardized care and order set that keeps workflow smooth and more reliable.
Great. All right. Well, Dr. Jordan, sorry, just got married. Congratulations, by the way. Dr. Jordan and Dr. Forbes, thanks for coming out and chatting with me today about this really important topic.
Thanks for having us.
Yeah, thanks for having me.
Thanks so much for listening today. If you would like to find out more about the AHA Hemorrhagic Stroke Initiative, please visit www.heart.org/hemorrhagic stroke. See you next time. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device.